Hello everybody, I'm going to share my tips when I respond as RRT to see a patient with bradycardia. Whenever I respond to any code or any RRT, I always follow ABCDE rule. A is airway, B is breathing, C is circulation, D is defects, deformities, and neurological problems, E is exposure and elimination. We are not talking about ABCDE rule, but always keep in mind when you respond to code or RRT. Okay, so when I go as RRT leader or as a RRT team to see a patient with bradycardia, I always go and check on patient, because if my patient is asymptomatic, then I have some time to get new set of vitals and EKG. EKG gives us a lot of information, vitals give us a lot of information, because vitals show us if our patient is not having the signs of bradycardia. Okay. And if my patient is asymptomatic, I also think about 5 major differentials. Although bradycardia has different causes, but I keep in mind only 5 causes which can kill patient or takes my patient life. That is myocardial infarction, which is number 1. Number 2 is congestive heart failure. Number 3, medications like beta blockers, calcium channel blockers, digoxin. Number 4 is hypoxia. And number 5, electrolyte abnormalities, specifically hyperkalemia. If my patient is symptomatic, then I start treatment right away. I start giving 1 milligram atropine, which I repeat every 3 to 5 minutes, total 3 doses, maximum 3 milligram. While my team is giving atropine, I always think other options if my patient is not going to respond to atropine. So other options are transcutaneous pacing or epinephrine infusion or dopamine infusion. If I plan to proceed with transcutaneous pacing, I always give analgesia to my patient. I use the same defib machine, just press the pacer button, then adjust the heart rate to 60 to 70 beats per minute, adjust the current, so every beat should be captured. Once my patient gets stability, then I get a new set of vitals. I check the pulse, especially the femoral pulse. If I plan to start dopamine infusion or epinephrine infusion, the dose will be different. Dopamine dose is 5 to 20 mg per kick per minute, and epinephrine infusion dose is 5 to 10 mg per minute. You can titrate as the patient responds. When my patient gets stable, then I call the cardiology, get their recommendation. Might be they will plan for transvenous pacing next day or at the same time. So I will also share some more tips with you when I work in the hospital and use these tips as a quick solution. Thank you so much for watching this video.